With that said, I think since we reached close to 70, we can go ahead and get started, and then people will join as they come in. So I'm going to start off by introducing Dr. Nicole Salazar Austin. Dr. Salazar Austin is a pediatric infectious disease instructor at Johns Hopkins University School of Medicine. She studied medicine at Harvard University, trained in pediatrics at the Children's Hospital of Philadelphia. During the course of her training, Dr. Salazar Austin worked in South Africa and Botswana, where she performed needs assessment in Waibangi Hospital's infection control program. Without further ado, we're really excited to have her speak about pediatric TB diagnosis and treatment. Thank you so much. Over to you.
Cool. Thank you. So I thought we talked today a little about epidemiology, because it actually plays quite a big role in pediatric TB diagnosis, because a lot of pediatric TB diagnosis is clinical and not based on culture data the way that it is for adults. And then finally, we'll finish off on some treatment considerations for children and figuring out how to get them their medications. So starting off with TB epidemiology, this is sort of globally what we see. So there are about 7.5 million kids in the world who are infected with TB each year. About 1.2 million of those go on to develop TB disease. About 50% of those are less than 5 years of age, and there are about 750,000 children, or really adolescents, who develop TB. And of those globally, about 200,000 children are estimated to die of TB each year. And the vast majority of those are under 5, so about 80%. And then 96% of deaths are really in children who do not access treatment. So we don't see as high mortality in the United States because most of our kids access treatment. And once they're on treatment, they actually tend to do pretty well. And then just a reminder also that as with adults living with HIV, children living with HIV is also a significant risk factor. In the United States, about 4% of TB cases are in children, which is generally defined both by the WHO and by the CDC as under 15. So why they say under 15 and not under 18, it's a long story that's not worth going into. But for TB, oftentimes children under 15. About 10% of cases in the US are in adolescents or young adults, and less than 1% of pediatric TB cases are living with HIV. And so these are kind of the numbers to kind of show that here. The most children are non-US born, but there are a number of US born children as well who develop TB disease, but we'll get into those numbers in a moment. So TB cases for all ages are higher in urban, low-income areas and in non-white racial and ethnic minorities. And specific groups with higher LTBI and TB disease rates in the United States are immigrants and refugees from high prevalence areas. International adoptees end up being an important source for children. Travelers to countries with high prevalence, people who are homeless, and residents of correctional facilities. And then, their children. So a lot of the TB risk for kids follows the TB risk for adults. So these are the percentage of pediatric TB cases born outside of the United States by birth country. And this is showing the data from 1993 and then more recent data from 2015. The vast majority are not covered here, but the countries that are most common include Myanmar, Mexico, Ethiopia, Philippines, Honduras, and Kenya. So really from a wide variety of Latin American, African, and Asian settings. For transmission of TB to children, so because children aren't out and about in the world as much as adults, we can often make generalizations about how transmission occurs in pediatric populations, and they're often infected by an adult or adolescent in the immediate household. There is causal extrafamilial contact. So like people who don't live in the household who are a source of infection for young children. In particularly, we've had some cases in Maryland on farms who've hired migrant farm workers whose kids may be, you know, hanging out with these workers in barns or other indoor areas that have allowed for transmission. And unfortunately, in some of these cases, rather delayed diagnosis with resulting morbidity and mortality, just because TB isn't high on the differential in amongst, you know, I would say in this case, sort of white Americans living in rural areas who don't have traditional TB risk factors, except for the migrant farm worker who nobody thought about. Children rarely infect other children or adults. So children less than 8 years of age don't typically have a forceful enough cough to develop the droplet nuclei that are necessary to transmit TB. So we tend not to be so worried about young children and infectiousness, but certainly older children, 8 and older, and particularly adolescents can certainly transmit disease. So you've probably seen this sort of risk of progression kind of thing before. People get exposed, some people eliminate the bacteria right away, but if they don't, one of two things kind of happens. They either go on to develop TB disease right away, or the TB kind of like is there and it's asleep and it's latent and it's not causing them problems, and it may reactivate during their lifetime, or maybe it doesn't. And the risks that you've probably heard for adults are something like a 5 to 10% lifetime risk, or a 5 to 10 annual risk if someone is living with untreated HIV. For children, latency, and particularly young children, I've heard specialists say there's nothing latent about TB in children. And so children often sort of after exposure have a much higher risk of going on to early TB disease and a much higher risk than adults. And so this is just data recently published in Lancet around the risk of tuberculosis disease by age. And you can see here the 2-year incidence. So in the 2 years following their exposure, what their risk was for kids under 5, 5 to 9, 10 to 14, and then teenagers. And what has consistently been shown in the literature across time is that for kids under 5, there is a high risk of progression to TB disease, and that risk might be even low, or might be even, higher for the younger you go, so that under 2s are even higher risk than those 2 to 5 years of age. In school age kids, 5 to 9 years old and 10 to 14, the risk tends to be a little bit lower, but then for reasons we don't completely understand, something about adolescents and their hormones, the risk goes up during the adolescent period. And I'll just mention that for kids under 5, the risk is not only of TB disease, but also the risk of, there's also an increased risk of morbidity and mortality because children will have disseminated disease, including both miliary disease and TB meningitis. These risks over here show that even if you don't have a positive, or these are the risks of kids who have a negative TST, or tuberculin skin test, or IGRA, or wherever you measure TB infection. And so there is a small risk of disease, but it's pretty small for kids who are who don't have a positive test, at least at presentation. These data are global and are not from the US and don't necessarily reflect a second test 8 to 10 weeks later. As far as the risk of progression to TB disease, so age groups certainly make a difference. Infants and young children, as well as post-pubertal adolescents, are at high risk. If you've recently been infected, the highest risk for children is in the first 6 months after infection, but that risk does remain high for 2 years. Recent immigration, in the sense that they may have recent infection, and then immunodeficiency. And for kids, this can include HIV, though a little less common in the United States. Hodgkin's disease and other types of cancers, as well as diabetes, chronic renal failure, and malnutrition, as well as immunosuppressive drugs. And this ends up being a pretty key reason why children end up having IGRAs and tuberculin skin tests. So just to say, these are the numbers from 2015 that include children less than 15 years of age. So certainly the overall numbers for children are low, and it is a fairly uncommon diagnosis in the United States. And so it is a diagnosis that requires a high index of suspicion. By site and disease, the vast majority of kids will have pulmonary disease, but nearly a quarter will have extrapulmonary or both. And then for extrapulmonary and involvement, we see a lot of lymphatic disease. We see a fair amount of TB, meningitis, and miliary disease, and small amounts of bone and joint disease, among others. So how children typically come into care, there is, they may present to an emergency room with a symptomatic illness and get worked up in the hospital setting and started on TB treatment there. And the second major way is discovery of a child with pulmonary tuberculosis during a contact investigation of an adult with TB. And in these cases, they may have few or no symptoms. The evaluation includes for all young children, the TST or IGRA, depending on their age, as well as a chest X-ray. And they can have, minimally symptomatic disease, but still have an impressive X-ray that can lead to a diagnosis and treatment. Up to 50% of kids are discovered through contact investigation, and before significant symptoms have developed. So how do we diagnose kids with TB? So oftentimes you'll hear people say, oh, it's so difficult to diagnose a child with TB. And I would say it's actually quite easy to diagnose a child with TB. They have pretty characteristic collection of signs and symptoms and X-ray findings. But in the absence of a pediatric ID person or a pediatric TB specialist, because we see so little TB in the United States, you won't find that every pediatrician is comfortable enough with the presentation and to kind of make that diagnosis. And so what you'll often hear people say is, oh, well, the signs and symptoms are just nonspecific. And, they can have fever and poor appetite and poor weight gain and weight loss. They can have pulmonary TB or they can have extrapulmonary disease, and all of this kind of makes it hard. But I think what's often the characteristic sign of TB is just a subacute presentation, where parents may not even, fully recognize that things changed because it happens so slowly and so subtly. And it really requires some pointed questions to kind of understand and point that out over time. It's not like a pneumonia that happens overnight or a meningitis that happens in a couple of hours. It's something that happens over the course of weeks, oftentimes. Physical examination may be normal, but isn't always. And there is often, but not always, an epidemiologic link. It is important to understand what that link is, because oftentimes we don't have an isolate for children. They have paucibacillary disease, and the diagnostics that have been developed for adults do not always prove positive for children. And understanding their source cases, drug susceptibility pattern, will be important in designing the treatment regimen for the child whenever possible. Other times, the child recently moved to the United States, they came from a high burden setting, there's no family member with TB or that had TB, and you make a best guess based on epidemiology. So key messages I like to get across about TB diagnosis is that a clinical diagnosis of TB is not difficult. Bacteriologic confirmation of TB disease is difficult, but not necessary for a diagnosis. And that diagnosis of TB disease requires a high index of suspicion. So when I evaluate a child for TB, these are the symptoms I often ask about, and the symptom screen that's recommended by the World Health Organization. I ask about fever of any duration, cough of any duration, neck mass, and particularly looking for those lymph nodes. Wheeze in particular that doesn't get better when taking some albuterol. So not typical of asthma. Weight loss or even just poor weight gain. Oftentimes with families, I ask about clothes being looser than they used to be, or asking if pediatricians are worried about their growth on a growth curve. We ask about lethargy, fatigue, and reduced playfulness. So I think reduced playfulness ends up being a pretty early sign of TB disease and is often helpful in getting me towards a diagnosis and to really helping the parents understand that something actually is not right with their child, even if they haven't recognized it yet. And so understanding that the child used to like run and play, and now they kind of, well, they play, but like they do a lot of stationary play and they're not running around and they don't seem to have as much energy as they used to. As far as cough, I think cough can always be a little complicated in kids because they do get so many viral URIs and because asthma can cause cough and there's just a wide differential for young children. But I think what's shown here and what's highlighted in orange is really that kids with TB often have this sort of persistent non-remitting cough that just gets worse and worse over time. And that may be overlaid with an acute cough with a delayed recovery associated with a viral URI, or some delay in recovery as a result of asthma. And so sometimes it does mean understanding, okay, well, you have a cough now because you have a runny nose and congestion and a sore throat, and that's all a viral URI. But before that happened, was there a cough and was it slowly worsening over time? And sometimes you have to, use the test of time and also let the viral URI run its course and then reevaluate the child thereafter to understand that, yeah, there really was this like background worsening cough that was made worse by an overlying URI. Pediatric TB symptoms do vary greatly. There's no single symptom or collection of symptoms that do define TB disease in children. It's really a combination of symptoms that provides good diagnostic accuracy in HIV negative kiddos. And so here, work has been shown to say that if you have a persistent non-remitting cough for at least 2 weeks, you have documented weight loss or failure to thrive, so you've kind of fallen off your growth curve a little bit, and that you have reported fatigue, which is perceived as decreased playfulness or activity, is all concerning for TB disease. These will still only identify about 4 out of 5 children, and the way that 5th children is often identified is really time, which is the best diagnostic predictor. If you make an intervention, maybe you give some amoxicillin, some antibiotics, and they get better, it's not TB. If it is, if they don't get better, after your intervention and you think you've identified all of the other causes it could be and treated them, then oftentimes TB is your answer. And so you don't always get the answer immediately, and time is often used to help understand symptoms. Obtaining a growth assessment and understanding the child's growth over time is critically important. Here in Baltimore City, our nurse managers know never to contact me about a patient without first contacting their pediatrician and getting a copy of their growth curve, which is something all pediatricians in the United States will have. If someone's recently immigrated, they may not have a growth curve. You'll often have a wait from like on a B waiver or something like that. And in many countries, young kids will have sort of a road to health card where they are actually expected to maintain their own growth chart and bring it to people as needed. And oftentimes families will actually bring that to you, which is incredibly helpful at both understanding what their previous vaccinations have been, which almost always include BCG, and then also understanding their growth over time. And I think here the important thing to understand is that weight loss in a child is in a young child is very rare. It's more common that a child just starts to not grow as fast as they should, and they start crossing weight lines. And so here, this is weight loss, uncommon, failure to thrive, where they start crossing these sort of lines is more commonly what we see. And particularly in the United States, to have true weight loss often means you've been sick for quite a long time. As far as what chest x-rays may look like, I will say kids and x-rays are a little more challenging. They don't often have the big right upper lobe pneumonia with or without cavity in the way that adults commonly do. And they have a wider presentation of intrathoracic disease, which makes chest x-ray reading a little bit harder. Although I think there are still ways you can diagnose and understand TB disease in these young kiddos. And so sometimes a child will really just have like a Gone complex somewhere that may or may not be visible. And what all you can really see are these kind of hilar lymph nodes. And what you look for is sort of a wider hilum than usual, or on the lateral we'll show you, but you can kind of look for some of these lymph nodes on the lateral film.
I don't know why my buds won't work anymore when I plug them in. Why not, Ashley?
I think if everyone could just mute themselves, if unless you're trying to ask a question, that would be super helpful. For lymph node disease, sometimes what lymph nodes can do is actually compress an airway, and you can have lobar collapse thereafter. Lymph nodes can also sort of break open into the airway and cause a bronchopneumonia. You can also have just a lobar pneumonia in kids, which can be associated with a cavity, but not always. And that may be in an upper lobe, but it may also be in a lower lobe. Kids will also have miliary disease, which is like those little seeds that look like they're coming across your chest X-ray. Kids will more often have pleural effusion. Well, I would say older kids will have pleural effusion. Sometimes they will have a small effusion associated with the pneumonia. Pericardial disease is a little more common too, which you can see in young children, or children really. And then this adult type pulmonary disease with cavities doesn't usually happen until kids are about 8, 9, 10 years of age. Certainly you can see it in adolescence. So these are the chest x-rays associated with TB disease that I thought we'd just take a look at for a moment. Sometimes you have access to a radiologist, pediatric radiologist, that will help you read these. Sometimes you don't. We're always happy to take a look and to see. Here, what they're showing is kind of uncomplicated lymph node disease. So the hila are just a little more full than they really should be. And the same over here. Here, this is again hilar disease, where the lymph nodes here and really the paratracheal nodes are really causing something that's wider than it should be. This over here is a little confusing because this is the Sales sign in a young child, and this is actually their thymus and not lymph nodes. And that always tricks people and does make it a little bit harder and challenging to identify these sort of paratracheal nodes. The other thing we do, I always trace down the airway in all kids I'm looking at for a chest X-ray and TB. These lymph nodes can compress airways, and that's sometimes indirectly the best way that you can detect TB disease. It's also really important to get lateral X-rays. You will often see a sort of horseshoe of normal structures within the hila, and when that horseshoe sort of closes upon itself and becomes a full donut, that often represents lymph nodes. And we do that in at least kids under 5, but to be honest, I just like laterals, so it's really helpful to see behind the heart and other things. So that's what we often see there. chest x-rays, any lobe of the lung may be involved. It's not just upper lobes. You really need good technique and experience with children. We often get the PA and the lateral, and really does take some careful interpretation to find that. TST and IGRA. TST and IGRA are imperfect. TB disease, particularly severe TB disease, can be immunocompromising and can actually induce a negative TST or IGRA. And so there is imperfect sensitivity. Children can definitely, about 10 to 15% of children will have a negative TST or IGRA, despite the fact that they really do have TB disease. And so the sensitivity is not perfect. And then the IGRA also doesn't distinguish between infection and disease, right? So you can have just a normal pneumonia and a positive IGRA, and that doesn't mean that you definitely have TB disease, although certainly that would be concerning, and we might take a closer look at you and make sure that you really do recover from whatever pneumonia you appear to be responding to with Amox or whatever else it's being treated with. So we do have limited diagnostic confirmation in pediatrics, and the reason for that overall is that kids have paucibacillary disease, which just means they have on like 3 to 4 times, 3 or 4 orders of 10 less bacilli in their chest than many adults do. And all of our current really TB diagnostics are dependent on high bacillary loads. So we literally look for bacilli in the sputa, either through expert or through or with culture, and we don't always find that in young children. Only about 1 in 3 children with TB disease will have a positive expert or culture. Well, really culture. Expectorated sputum is also not so easy to obtain from young children. In the US, this often requires 3 early morning gastric aspirates. It's not usually performed as an outpatient and often requires hospitalization. Induced sputum is something we're doing now in the Baltimore City Health Department. I hope more health departments start doing it. Bronchospasm is something people often bring up. It's extremely rare. And there are infection control concerns, but ideally we all work in places where we've already considered infection control from a TB perspective. BAL is always a possibility, but the sensitivity may not be as good as gastric aspirates, and it's pretty invasive. So I haven't seen it done commonly. Stool expert is now available globally, but not in the United States. The FDA has not approved stool. Urine lamb is also available globally, but not in the United States. So for current diagnostics, a smear microscopy will only probably be positive in about 10% of kids with TB. Culture will be positive in up to 40% of kids with TB under extremely optimal circumstances. And then an expert is probably only positive about 25 to 30% of kids. So just to say, confirmation is limited and clinical diagnosis is critical to finding children with TB disease. I will say collection of multiple specimens always improves yield. So even if you do an induced sputum, I would do multiple. And this sort of concept of ruling out TB disease with 3 sputa in adults is just not applicable to children. And I will hear doctors and folks say that sometimes, but it's really with a sensitivity at best of 40%, there's no ruling out anything with any number of sputa. Expert has a pooled sensitivity of 73%, but that is compared to kids with a positive culture. So these are kids who already have bacteriologic confirmation. Expert will confirm that in about 3/4 of them. So about 1/4 of the kids who have expert or have a positive culture will have a negative expert, but the 60% of kids who have a negative culture will not have a positive expert. So culture is still the best way to diagnose kids. Expert is very, very good, but not perfect. And at this point, nothing is really better than culture. as far as diagnoses go in the United States, there is only about 26% that are lab confirmed. 52% are a clinical case, and I'm not really sure what's meant by a provider diagnosis. I have a feeling that's just really 74% that are clinical diagnoses, and about 26% that are lab confirmed. I'm showing pictures now of kids with extrapulmonary TB because I think it's important to just think through what kids present like. Oftentimes you'll just see unilateral, sometimes bilateral big nodes. Occasionally those nodes will come to the surface, open up, and you'll see drainage. That can leave a lot of scarring. Hopefully we find it before then, but I've certainly seen that. And the differential for that is certainly a non-tuberculous mycobacterium, which is not that uncommon in kids who live in the United States who are 2-3 years of age. So if they don't have TB risk factors and a negative IGRA, certainly send them to a pediatric ID specialist because NTM should also be considered. But just other examples of lymphadenitis. Other examples of extrapulmonary disease, certainly think about the abdomen, think about joints. In particular, the spine can be a place that we see TB commonly in young children. So for TB treatment, you know, we, you know, when culture results are available, we use obviously the drug sensitivity testing from the child itself. When either the child's parents refuse a gastric aspirate, it's not possible to do for whatever reason, you're only coming in to the situation well after the diagnosis, you know, you use the source cases, drug susceptibility testing to guide your drug choice. And if you have none of that information because you don't know who the source was, or because they've moved on and they were a migrant farm worker or whatever the story is, then you use your best guess in epidemiology and often involve a pediatric TB specialist at that point. When resistance is possible or suspected based on epidemiology, I do tend to be a little more aggressive with my diagnostic approach. So if you have a kid who lives in a household and everyone who has been diagnosed with TB in that household has drug susceptible TB, I may not push to have many gastric aspirates done. If that child is coming from another country with high rates of drug resistance and grandma's been treated for TB 3 times, including once with streptomycin, and she's never had a DST, they've just, you know, treated her 3 times with drug susceptible TB, for example, you know, I might be a little more aggressive in my sampling to try to get a DST because I may feel that there's if there's a higher risk of resistance, I will be more aggressive. Risk factors for drug resistance, certainly contacts of patients with known drug-resistant TB, prior TB treatment, which tends to be a little unusual for young children, but not impossible. Poor initial response to therapy, sort of persistent smear positivity after appropriate amounts of treatment, and then immigration from or to countries with a high prevalence of DRTB. Your first line therapy in kids is not really that different from what you see in adults. You have rifampin, isoniazid, pyrazinamide, and ethambutol. The doses are based on mg per kg. So there's not, you know, one standard dose across all. And these are the mg per kg doses and the range that we typically use. And then I've also listed the sort of formulations here. There are capsules and solutions and tablets. I will say I don't use a lot of oral solutions. They're not always easy to get from health departments. They also are very large volumes, and particularly the one from INH is associated or just induces a lot of nausea in young children. And so I just don't, most people don't prefer them. It's actually usually easier to use crushed medications and put it in a little pudding or applesauce or something, and then sort of immediately give it to the child. For rifampin, they don't come in tablets, it's an oral capsule. And so oftentimes I'll open the capsule and use the contents as kind of sprinkles and give that to the kiddo. The side effects for kids are similar to adults, but happen far less commonly. Important things to remember about a rifampin is that it is an inducer. So the most common meds that this comes up with are oral contraceptives, seizure medications in children, and other antibiotics. For hepatotoxicity, rifampin is pretty uncommon, as is pyrazinamide, but it certainly can happen. Isoniazid is the more common of the bunch, but happens less than 1% of the time. And I usually send families home saying something like, if this kiddo is really nauseous and loses the appetite and starts throwing up, and not immediately after the drugs, but really like between the drugs, then I want to hear about it. And particularly for LTBI therapy, I say to stop treatment. And usually there's someone doing DOT and checking in every day. So it's not so, you usually hear about it right away. Practical administration to young kids. So again, I really tend to crush and mix with food. There's been testing and there's good stability in sugar-free chocolate pudding or grape jelly, but I'll be honest, I use whatever the kid likes. And whatever seems to mask the taste or the bitterness of the crushed medications the best. I think the key point is crushing it and getting it into the kid very soon thereafter. Don't crush it and wait an hour, which generally doesn't happen because you're doing this DOT anyway. But if it's a video DOT or whatever, just making sure the parents know they should crush it, put it in the food, and then immediately give it to the child. You can absolutely use suspensions. You need to in very young children, less than about 7 or 8 kilos, because the tablets are too big for them, or it's just too much drug for their weight. But after that, the volumes do get quite large. And unless the kid has a G tube, I haven't seen many kids that aren't babies prefer that. And crushed isoniazid is almost better than the liquid isoniazid because of the GI upset caused by some of the other things that are not isoniazid, that help maintain the stability of that solution. People always ask about ethambutol in children and whether or not it's safe. There are concerns around loss of color vision and just sort of ocular toxicity with ethambutol. That was seen when ethambutol was used at higher doses largely, and not at the sort of bacteriostatic doses that we use now. There's been a review by WHO which does suggest that at this lower dose, ethambutol is very safe in children, particularly when you're only using it for a 2-month period. When I do use it longer than 2 months, I will often have ophthalmology follow-up. But if I'm using it for 2 months or less and just for that sort of initiation phase, I often do not use ethambutol. I do use ethambutol. I don't send them to the ophthalmologist. And I think when ethambutol is particularly important is when the susceptibilities of the source case are unknown and you're not sure whether or not there could be INH monoresistance. If you know the source case has pan-susceptible TB, and it's susceptible to RIF, INH, and pyrazinamide, I often in those cases don't use ethambutol. I do use it if there's extensive adult type or smear positive pulmonary TB disease, particularly in those adolescents, to reduce the risk of the development of resistance. And I will also use it in severe forms of extrapulmonary TB. Following response to therapy in children is again very similar to what it is in adults. There's a clinical response, there's a microbiologic response, and there's a radiologic response. So clinically, you want to see improving symptoms. You want to see that they start growing on their growth curve again. And if there were any developmental delays, or even if they're at their stage, that they continue to kind of develop normally and either regain whatever milestones they may have not achieved in time, and that they continue to achieve their developmental milestones. Microbiologically, we don't love repeating sputa in young children if we don't have to, but certainly if their initial test was positive, and particularly if they have drug-resistant TB, we will often continue to assess samples for conversion. I will say that happens in a minority of patients, and is really not the norm. Radiologically, repeat chest x-ray is not mandatory. Chest x-ray often lags behind true improvement. It's often helpful when a child hasn't shown significant clinical improvement and there's some kind of concern that maybe things are not going as they should be. And just a note to say that hilar adenopathy can take 1 to 2 years to resolve. And so I don't use repeat chest x-rays and the persistence of adenopathy at 6 or 9 months to define the duration of therapy, or you'll be treating that child for a very long time. Following response again, so we use directly observed therapy, either in person or on video. I don't think being a child means we can't do it on video. We've had good experience here in the city and in the county in Maryland with using EMOCA and other such programs to do video DOT in kids. I usually follow them monthly as the physician, looking at symptoms, weight gain, developmental milestones. I look for drug toxicity, particularly that nausea, vomiting, abdominal pain. I look at adherence and weight adjust all medications. And particularly for those little kids, it is important to make sure that as they grow and they gain weight, and particularly if they've had TB disease, they can often gain a lot of weight right at the beginning when you start medications, that we adjust those medications for the weight so that they remain on good doses for the full duration of therapy. Drug-related hepatotoxicity is pretty rare, but it can happen. Liver function testing is really only indicated when there are signs and symptoms of hepatitis. Or I will also do it if there's some baseline liver abnormality, or that may heighten the risk for hepatotoxicity, but I do not draw bloods in all children, in otherwise healthy children, as treatment continues. For treatment duration, and that's a Red Book AAP recommendation as well. Treatment duration is usually, well, this is actually a bit of an old slide, but it's 4 to 6 months for pulmonary TB, longer for TB meningitis and TB osteomyelitis. We can extend therapy for poor response to therapy, cavity with persistently positive smears at 2 months, and poor adherence. And I'll just say that there is sort of a new paper from the New England Journal that say kids with non-severe disease can, and there's a list of criteria, can undergo 4 months of disease. That is, being rolled out at various degrees by various states in the US. It's now a recommendation in the 2024 Red Book. And so it is out there, it is being recommended. And I think I couldn't say how various other states are implementing this. In Maryland, what we're doing for the 7 or 8 kids who get diagnosed with pulmonary TB disease each year in Maryland, I'm reviewing their cases and kind of seeing whether they are a candidate for the 4-month regimen. I think every state will probably be a little bit different in how they do that. And I know there are a lot of ongoing conversations with TB programs, so stay tuned. I think that will evolve in the next couple of years. So I have a clinical case that we can go over now, or we can stop, have a discussion, ask some questions, and we can go back to cases if we have time. I'm kind of happy either way, but maybe we'll leave that up to you.
Does anyone have a question? If you have a question, can you please put it in the chat? I think we could do the case today. That'll be really helpful. But I just do have one question while we're right on that subject of the 4-month regimen. The new recommendation, is that still have an initial phase and a continuation phase? Do you drop the meds? Do they stay on all 4?
Yeah, no, that's a good question. So for this, for the Shine regimen, it's really just dropping the last 2 months. So there's still 2 months initiation phase and then 2 months of RH thereafter instead of 4 months of RH thereafter. So you actually really can make the decision at the 4-month mark. There's no reason, oftentimes we make the decision and the criteria aren't really based on response to therapy so much, but like your presentation at baseline. But you can't, I mean, the therapy up until that 4-month mark is the same. So you could make the decision at the end and not the beginning.
Oh, great. Thank you for that.
Yeah.
So we have about, I guess, about a good 10 to 12 minutes before we open it up again for discussion. So if you want to do the clinical case, I think everybody would really like to hear that.
Sounds good. All right. So this is a 2-year-old who's coming in with 2 weeks of daily fever to 40 degrees Celsius or about 104 degrees Fahrenheit after recent travel to India, where she kind of spent a month hanging out with her grandparents and family, but didn't really do much other than that while she was there. There wasn't a lot of, it was the summertime, parents were working, grandparents were kind of just hanging out with their grandkids. They did have her like join a play group at like a creche or like a daycare for like 1 or 2 days a week, just so that she could interact with other kids her age. No one in the household was known to have TB. There was an outpatient workup, which at 2 was fine now, but wasn't then. She was quantiferon positive, but like 10 out of 10. So like when you do these sort of IGRAs in young kids, if it's positive, it's positive. If it's negative, that's where you're like, well, but what is the sensitivity and is that perfect? And then they had and then she had a chest x-ray which showed a left lower lobe pneumonia. She was admitted to the hospital, started on routine IV antibiotics for community-acquired pneumonia, particularly ampicillin, and then also had 3 consecutive early morning gastric aspirates. And then towards the end of therapy, her fever curve really wasn't improving on ampicillin. She also never had any like decreased oxygen saturation or really increased work of breathing that goes along with a community acquired pneumonia. She had a chest CT to kind of better define the extent of her lesions and any adenopathy that may have been there. And so this was her original film from the outpatient setting. And I'm trying to remember, I'm actually not sure that it is. It may have been her admission x-ray, but certainly some disease here that can also be seen here. So following given that she didn't really have clinical improvement to the amoxicillin and she'd been in a high risk setting and she had a positive IGRA, we started her on first line therapy with HRZE and followed her closely thereafter. Her fever kind of resolved. She had appropriate weight gain. She had downtrending, but not resolved inflammatory markers. And although her high-grade fevers of 104 kind of resolved, she continued to have these like low-grade temperatures. None of them actually technically met criteria for a fever, but they were all kind of like this 99, 100, 100.1 kind of thing. And Dad had thought there was like Dad, who was a physician, felt like there was some associated tachycardia with those. And again, for her age, like those, it was like on the high range of normal, but wasn't wasn't technically tachycardia. One of her 4 gastric aspirates was positive at around 4 weeks. There was no growth on solid media, and so no susceptibilities were available. And at this point, I was kind of seeing her at probably like let's just say like the 8-week mark and deciding on continuation phase or not. And was concerned that maybe, you know, was this a complete response to therapy or not? And so I think for her, this was a case report, so we've like nicely laid out her symptoms. But in this first 12 weeks where she got HRZE, you know, her weight largely improved, her temperature came down, but didn't completely normalize. And her CRP had really downtrended. So there was a lot of positive movement in the right direction. But I'll tell you honestly, like normally kids get back to normal faster than that. And a lot of these things were subtle, but they were present. And so we repeated her chest CT, and you can see here that that the lesion had actually grown in size. So this is like the transverse cut initially, and this is the pneumonia. And now when we repeated it at 12 weeks, it was quite a bit bigger. And not like chest x-ray, delayed, but bigger. And I think here and this nice like modeling that Sanjay Jain and his group did, really you can see that this lesion here is quite a bit bigger than this yellow lesion here. And so she ended up eventually we did her midget culture that was positive did grow on LJ slant, and we were able to do susceptibility testing. And we learned that at that time she had XDR TVs. This is a little like, this is 10 years ago. This was pre-bedaquiline and delaminid. And so we started her and treated her for a total of 21 months on streptomycin, linezolid, PAS, cycloserine, and clofazimine. And she did super well and grew nicely over time. And has been cured. And in the, I don't know, now it's been almost 8 years since I saw her as a patient, and she has not had any kind of recurrence, which is fantastic. But just to say, it's not that she was asymptomatic, but that her symptoms were somewhat subtle. There are lots of resources to treat drug-resistant TB in patients. There is still somewhat limited PK and safety knowledge for many drugs at younger ages, but we do now have dosing for bedaquiline and delaminid down to 3 kilos, which is essentially the weight of a newborn. And those are all in the WHO operational handbook on TB. And many of those also appear in the Red Book. There is somewhat limited availability of these formulations in the United States, but they can be obtained with help. And pediatric ID specialists and or TB specialists can help you sort a lot of this out. Tuberculosis in adolescents, I'll talk about for a moment. So adolescents develop TB in one of two ways. They can really like progress in the way young children do after recent exposure, or they can reactivate infection from infection that they acquired during childhood. And so their disease can look like pediatric disease, or it can look like adult type reactivation disease, which I think is important because they kind of span the gamut and on how they present. Their constitutional symptoms are often more prominent than respiratory symptoms. They'll have weight loss and fever. They'll have drenching night sweats, and then cough, chest pain, and hemoptysis. Cavitary lesions are less frequently seen, but I am currently caring for a patient with 3 cavitary lesions, so it is certainly possible. Ooh, I don't know what that. So from an adolescent TB case, there is, well, you know, she's aged, not really an adolescent, but she's an 8-year-old girl. That's why. At 8 years old, she arrived from Haiti and was evaluated at the health department for a 12 millimeter TST reaction. There were no symptoms of TB disease, and her chest X-ray was done, and it looked like this. And so she was prescribed INH, and she got 6 months dispensed, but it was kind of written as overdue for medication refill. And so she and then, you know, she kind of just was lost to follow up and out of care for the next 5 years until she was admitted when she was 13 years of age at a local hospital with 3 weeks of fever, cough, dyspnea, and weakness. She'd been sent home by a school nurse on 4 occasions over the previous 4 months with fever and cough, and then for weight loss and weakness. She was seen a couple of times by her PCP, who gave her azithromycin, and twice by emergency room doctors of local hospitals. At the last ED visit, she which was 9 days before she was admitted, she had chest radiographs were done and she was prescribed Augmentin. There was no improvement with the antibiotic. And these were the chest x-rays done in the emergency room. So a lot of diffuse disease throughout here. So on exam, she was cachectic, weak appearing, flat affect, and mild respiratory distress. She had a fever of 103.2, heart rate in the 160s, respiratory rate of 22, and an oxygen saturation, which was okay at 92%. She was started on IV ceftriaxone and oral azithromycin. ID was consulted. They said get sputa. She was smear positive, culture positive, and pan sensitive. She was started on RHZE. I'll just say here, you know, these sort of like missed opportunities by the school nurse, by the PCP, by the ED are unfortunately like very common in all of our patients, but I think particularly amongst adolescents, and oftentimes just, you know, result in worse disease. And maybe I'll just share a moment of my experience with a current adolescent who we have been struggling to treat here in Maryland, who had, I think, been just sort of like pocketing drugs in her mouth, even though she was getting in-person DOT, and like initially had shown like real improvement in her smear over 2 months, but then clearly just stopped taking her meds. Her therapeutic drug monitoring was now 0. We struggled to understand if that was really like a lab error. The culture data was kind of cooking, but her time to culture positivity decreased, her smears increased. It was clear she just had stopped taking her medications, despite the fact that she was getting in-person DOT, and somehow kind of just like pocketing the meds in her cheeks and must have been flushing them later. Mom didn't realize. Mom was very upset when the health department confronted mom about it. And ultimately she had a 2-week hospitalization and a lot of psych involvement, and she's now taking her meds. But adolescents can be tough. And we expect the unexpected, and I don't trust anything to be fact, and I question everything, but not in a bad way and not necessarily directly to the patient. But somewhere in the back of my head, I'm always thinking, but they might not really be taking their meds. So that is it for now. Happy to answer any questions, and talk about anything you guys might want for another 10 or 15 minutes.
Great, thank you. That was a great presentation. So based on her not taking the medication for TB, is it safe to say she might not have taken it for LTBI, which resulted in the TB disease?
Yeah, so this is someone, I've learned more about her over time, but yeah, we have had adolescents also just like not take their LTBI, including people who were like, you know, like there's like the people who come in as B waivers or come in from their PMD, and right, like that's always hard. They don't have a lot of like increased support. And then there are household contacts. And we do DOT for kids under 5, but we don't do DOT for adolescents and all household contacts. But oftentimes those people get like a little bit more love because there's someone going into the household now and again, and there's a case manager and for the index patients. So like they get a little more attention over time. But the truth is, like, yeah, for this adolescent that I presented, and also the adolescent that I recently treated, both of them were previous or I've had several previous household members or parts of contact investigations who somebody thought they took LTBI therapy, or in other cases, like they didn't really, like they got lost for some reason. And then they come back years later with bad disease. And a lot of it. And this kiddo, it's always tough, right? Because like she took her medicine for a while, she did better. But then, you know, for whatever reason, just kind of like lost hope and stopped taking meds, and then was like really sad that she couldn't go like back out into the community and see her friends. She's not going to be able to start school next week. And I was like, it just stinks, because if you just continue taking your meds, you would be going to school next week. So like we had a lot of like if thens, like, you know, you got to take your meds. We're doing like more smears for her than kind of usual, to help her see her progress over time. And to allow her to kind of motivate her to keep taking her meds. And she's involved, has like outpatient psych and on with like video visits to kind of support her as well. But yeah, it's these cases are always super hard.
Yeah, this is a really good question. This is kind of a question I've had too. Like, please help explain at what point and how the earlier missed opportunities may have been handled in the case study, directed for follow in what way, please? So I guess, you know, there was a lot of misdiagnosis, I believe they might be talking about.
Yeah. I think oftentimes, right, like for whatever reason, people are just busy. It's a busy ED. It's a PMD who doesn't think a lot about TB. Maybe they don't have a lot of people with positive TB tests in their clinic, and so they don't think about TB a lot. And so they don't think about a kid who keeps coming back and keeps getting treated over and over and over again for pneumonia. And has a positive history of LTBI. Like, to me, like that, like we see these cases and it's just like, well, that's so obvious, but that's what I do, right? I see TB all day, and so you see 100 stories and you see the commonalities. I think for people who see this like 1 in, 10,000 patients, like they're like, oh, well, I don't know why they didn't get better, or maybe they just got reinfected. I don't know. I just need to get them out of my ED because they're not that sick, and they can, and I need to go see the next patient. And so some of it's just like healthcare, right? Like, but ideally what somebody would have noticed is that this kid has had multiple pneumonias, does not really get better with antibiotics, and has a positive IGRA, and maybe received treatment, but maybe didn't receive treatment for their TB infection. And so maybe this is all TB, and they should have either been referred, probably at that point, depending on how well they were, they could have just been referred to the health department versus getting admitted. For an adolescent who's like otherwise well and doesn't need to be in the hospital and doesn't need a gastric aspirate and can actually like expectorate sputum, like you might be able to work with the health department and do that as an outpatient evaluation, as you would an adult, right? But sometimes with younger kids, it does mean like admitting them and doing gastric aspirates, because they're not going to expectorate sputa. And depending on, and as much as I say I don't do gastric aspirates, that is kind of the standard in the United States, and it's very rare that people don't do it. Although I'm probably more comfortable than most not doing it in all situations, it does usually get done. So yeah, that's what I would say from a PMD perspective and or an ED perspective. An earlier call to a health department to label someone as a quote TB suspect and fill out whatever paperwork may be needed and faxed over, and then they get evaluated. And the health department, in my experience, at least here in Maryland, usually follows up quite nicely with all of these patients, and they usually don't fall through the cracks. There's always 1 or 2 that usually involve like homelessness, or people move, and then but there's always a story. Usually there's good follow-up, and people either get diagnosed or they don't. depending on, you know, the circumstances and the presentation. But that's how I would probably have advised, or what I could have seen happen earlier that could have avoided the severity of illness.
Yeah, unfortunately,
Nurses, I'll say, are just hard. Like,
I mean,
um,
it happens with adults too. It's hard to it's hard
Yeah.
to get everyone educated about TB. And like you said, because we see it so often ourselves, and then we see it being misdiagnosed, it's very frustrating. But any chance, I guess, that we have deal with the pediatrician, I always try to like send them something or educate them. If it's like following up on, they did a test for a kid for a contact, but they never really do TB, like just maybe that outreach to your pediatricians, if that's at all possible, is sometimes helpful. But I do have a question that this comes up quite often in questions that I get from nurses. So they're doing DOT on a child, and the child throws up the medication. Do they re-administer? What would be your thoughts on
yeah, that's a good
and
question.
any of that?
Yeah. So usually, like, so I will like, it's hard. So I will often re-administer if they vomit all of it out right away. Right. Like, I think it's always harder the longer it gets. So like after it's been 30 minutes, you're like, well, I don't know. What do I do? And then I think it's hard. But if like they kind of like vomit it all, and most people don't stay that long, you know what I mean? Like from a DOT perspective. So but if it happens like while you're still there and it's like within 30 minutes of giving the medication, and like you can kind of see like the like everything that they swallowed come back up, I will redose, and then I'll work with the family on what's going on around food and snacks and other things. I think traditionally we tell people to take TB meds on an empty stomach. For kids, that just doesn't always work. If they're just super nauseous with the meds, like they may just need to take a snack or like a small meal before taking the medications. And generally when I've done like therapeutic drug monitoring in those situations, like their levels are just fine. Like I don't think it's so problematic. And with new regimens coming down the line in HPMC, like that needs to be taken with food. So I think that'll also change with new regimens. But I don't force kids to take all their meds on an empty stomach, because you can't stop them from vomiting. And I'd rather them get most of their medication than none of their medication. And for that reason, and because they do spit out a little bit more, like there's like that whole range of medications where it's like 10 to 20 megs per kg for like rifampin, for example. And I always go to like the higher end, knowing that if they spit some out, they'll at least get like at least the 10 megs per kg. And maybe they don't get the full 20, but it's enough. I almost never dose at 10 mgs per kg, because if they throw it out, then they won't have enough meds. So, but it's also a challenge because you also don't want to give them so much medication that they just throw it up. So, I mean, I think working with the pediatrician and the person like writing the orders, along with understanding what's going on in the family, and talking to the DOT worker in those situations when that's happening quite frequently, like you bring everyone together and you sort out what's best for that patient, and you and you think through like the like whether or not you're giving liquids or crushed pills, and whether and what the dosing is, and how much they're throwing it up, and whether or not you need to give it with a snack, and what food vehicle you're using, and whether that may be the problem, and you just troubleshoot until you find something that works.
Yeah, that was another question about the empty stomach, and I feel like at sometimes it's the risk and the benefit, right?
Yeah, some drug is always better than no drug.
Right.
Yeah.
And I just have one last question about TB meningitis in children. Like what are some of the things they would present with or diagnosing it, or do you use any labs to diagnose meningitis in children?
Yeah, no, that's a good question. I think the presentation for meningitis for TB meningitis can often be nonspecific. And it can lead also to delays in treatment or to diagnosis and treatment that ultimately have big consequences for morbidity. And so what it presents with initially is really just like vomiting and persistent vomiting that doesn't, like it's not a gastro, there's no associated diarrhea, and they just vomit every day. And so they often end up going to see a GI doctor first. And vomiting in a young child, like in my residency program, like you should always think about when it's just vomiting and it's an isolated presentation of vomiting, like you should always think about increased intracranial pressure. And that's really what's going on in TB meningitis at that point. And sometimes people think of that and sometimes they don't. And when they don't, they'll often wait until there are more severe presentations that point to the brain a little bit more, like cranial nerve defects, or just like decreased like lethargy, seizures, or just decreased like consciousness. And unfortunately, all of those things, oftentimes, if you catch it right away, there can often not be like huge morbidity and mortality associated with it. But the longer it goes, the kind of worse it is. And I think at that point, what you see and for diagnosis is the key is really just doing an LP. And what you see when you do an LP, you kind of have like your reds, your whites, your protein, and your glucose. And what is really unique about TB versus many other infections is just a really, really elevated protein in comparison to where your whites, where your like the total amount of inflammation and white cells are. And that's oftentimes what leads people to the diagnosis of TB. We do experts sometimes on CSF. I think that's a little off label here at Hopkins. But to be honest, and there are like PCRs you can send through Quest and everything, but I've never seen any of that be positive, even in patients who have like culture positive TB disease. So I don't know what it is about LPs, but I've not had a lot of success in using PCR based technology to diagnose TB meningitis. It's really the clinical picture and the subacute picture combined with like that elevated protein in the CNS that convinces me someone has TB meningitis. And because of the high associated morbidity and mortality, like when you see that, you just, you whether you have confirmation or not, you start. And if they have TB, they'll hopefully get better. And if they don't, you might have to figure out what else they have. It's always a little bit hard. You don't always have confirmation, and sometimes you like that because it's a whole year of treatment and not 6 months, 4 to 6 months, but you usually feel confident enough with the clinical presentation and the CSF profile.
And now that we're going back to school, we have a question because this will come up quite often come September, of the children that went back to their high burden countries, and now they're coming back. What is considered significant period of time in terms of determining potential exposure? Like we have children that went on vacation for the summer, maybe to a high burden country, and then, now they're back. Should they be tested?
So the AAP says 1 week is all it takes, but it's 1 week like living in the community. So if you're like living with grandma and grandpa, auntie, daddy, like whoever, a week. If you're at like, I don't know, if you're in like Bali, staying at like some gorgeous resort, and you don't leave the resort and you're on the beach the whole time and you don't interact with the community in Indonesia, I'm not so worried. But if you're like staying with grandma and grandpa in Indonesia and like hanging out with all of your aunts and uncles and cousins and going in and out of households and churches and the community, all it takes is a week. So I have a pretty low threshold in people who go back and forth in doing IGRAs. And we've definitely seen, people who do that, who like a teenager a couple of years ago who went back and forth to the Philippines, had a positive IGRA. No one, like the parents were like, nah, I don't really want to treat that. Everyone has that in Indonesia. And then he ended up having miliary TB and too numerous to count tuberculomas in his brain. He did super well for how terribly he presented. But yeah, he just got it on a trip visiting family in the Philippines. The family was devastated and regretted their decision not to treat the LTBI, but you know, live and learn.
Yeah, unfortunately, good thing at least we can at least treat the TB now.
Mhm.
But it looks like we are at our time. So I just want to take the time to say, Dr. Salazar, thank you for the great presentation and taking the time to do this because it's greatly appreciated. And for everybody else, there's a link there in the chat for your evaluation. So please fill them out. And next week, we will be doing this at 10 o'clock again. Our TB 101 will be nurse case management, which I will be doing the nurse case management talk. So with that being said, thank you everyone. Have a great Friday and we will see you